So we're going to move into more clinical aspect of things. We're going to move on to presentation from reps from West Park Healthcare Center, specifically Matthew Lamb and Shirley Price. You want to come up?
Thank you. My name is Shirley Price. I'm the manager for Rehab Plus at West Park Healthcare Center. And this is Matthew Lamb. He's my occupational therapist. And we're here with, I'm really wearing two hats. Rehab Plus is an outpatient rehabilitation and wellness clinic, and we are part of West Park Healthcare Center. And we provide services on a fee-for-service basis. And so we've developed this back care program that we work with West Park, and some of our service is a purchase service. So I'll explain a little bit about that and how that works. Today we're here to talk to you about the back care training and safety program that we do for West Park. I'm going to give you a little bit of a background on the organization and the initiatives that has led us to the program we've developed for the center. And Matt's going to give a little bit more detail on the program and how he developed it and how it's delivered and some of the results as well. Okay, so, I already gave you the overview, so I'll skip ahead. So West Park Healthcare Center is a rehab and complex continuing care service. We have inpatient and outpatient services, and we have over 480 beds. Greater than 40,000 ambulatory visits per year, and we have over 900 staff. And the breakdown, as you can see here, between clinical staff, maintenance, environmental services, and food services, those are our largest group that we serve. Okay. So why do we do back care education and training? Basically, first of all, in 2008, 20% of all health work-related injuries were related to patient handling in Ontario. And research has shown that when you integrate equipment and education, you get better results than just making changes to equipment alone versus educating workers alone. And also, it's part of our best practice policy to have annual back care retraining and refresher courses for our staff. The program that we've developed, we've started with focusing on the clinical workers in the hospital, and this is something that the organization has done over the years, but the sustainability and the transfer and year over year continuing to keep people trained has been a challenge. We've tried different models in the past where at one point we had designated back care resource people across the organization in all of the clinical areas. They were provided with training on back care, education, lifting principles, safe patient handling, and they were on the units. And it sounds like a great idea. The back care resource people were responsible for training new staff as they came on, but it was very difficult with all the staff turnover, people transferring from one service to another or leaving the organization, bringing on new staff, to keep the back care resource people having their skills upgraded and updated at all times, and then keep following up with all new staff as they came on to make sure that everybody was trained properly. A couple of years ago, we tried a pilot on one of the units where the occupational therapist took responsibility for training the nurses on that unit. It was one of the more difficult units, or in terms of the heaviest lifting with total care patients. And we did see some success and some buy-in from the staff. And part of that was because the occupational therapist on the unit knew the patient population well, and they were able to use case-based scenarios in doing their training. That pilot had good results for the one unit. Another model that we had tried also in the past was having external people come in to provide training across the center. And again, there was less buy-in from some of the clinical people because having someone come in from outside, they didn't know the population, they didn't know the equipment we used, and there was a lot of challenge with the sustainability, again, of that type of a program. Also, in terms of identifying the importance of delivering this type of education, we looked at our population, of the clinical population, and just this is a graph to show you the relative age range of the nursing staff primarily. And as you'll see, we have 16% over the age of 60, nursing staff working on the floors, lifting, handling, transferring patients. Almost 30%, 40 to 49, and 26%, 50 to 59. When we look back 5 years, the data is very similar in terms of the shape of the bell, but there was only 11% in the over 60 age range. So we do know that our population is aging. We can expect to see aging in the workplace. It's not a scientific study by any means, and what we don't see is staff turnover as well, but we do want to make sure that the clinical staff who are doing all this heavy work are properly trained. So now I'm going to turn it over to Matt, I think. Let me just flip. Yes, I am. I'm going to turn it over to Matt, and he can talk to you about the program that we developed at West Park.
All right. I'm going this way. Okay, I just kind of want to go over to this side because I feel like all the presenters have been over there. And hi. Welcome. Okay, so in terms of the back care program at West Park Healthcare Center, we layered it quite a bit to make sure that it's multi-tiered and there's a lot of access to education and a lot of access to expertise wherever they go and wherever they are in terms of how many years they've been working in the facility. So the very first thing everybody gets is their orientation package includes a presentation on musculoskeletal injuries, and these are general. This is not just for clinical staff, it's for everybody. And it goes over basic ergonomics, basic back care. And our orientation at West Park is actually a 2-day orientation, and the second day is for clinical staff. That particular part of the orientation includes another presentation on back care, but this one specific to proper use of ceiling lifts and slings, as well as proper techniques for repositioning. We felt that that was particularly important, not just from a basic ergonomic perspective and a biomechanical perspective, but also from safety, and we thought that that was very, very important. The next thing that we have is either, well, actually biannually, our back care refresher courses. Now, these are courses that happen on the units themselves, and they are done in the environment that the nurses and the other clinical staff work. And we think that's incredibly important because you can set up a bed and you can set up a ceiling lift wherever you want, but it doesn't mimic the environment that people have to work in. You can show somebody mechanics on how to get a patient from the side of the bed onto a commode, but if you don't have all the other clutter and the other things within the environment, the mechanics don't necessarily make sense once you get somebody to actually go out onto the floor. So that's why we decided to do all of our presentations in the environment that the clinicians work in. Of course, you can't forget the general biomechanical principles. This is a relatively new part of the program, the back care refresher presentations. They only started in January, or maybe even just a little bit in 2013. So there have been nurses who said that they haven't been to or they haven't remembered being to a refresher course in quite a bit of time. So I always like to include biomechanical principles, the general ones, and not just, who's ever heard of bending your knees when you're lifting something? Yeah? Does anybody know why? Yep, big muscles, right? But you always want to know, what we want to tell the nurses is why they're doing these biomechanical principles. Because if they don't understand why, and they say, oh, I'm going to bend my knees. Interacting with a patient this way over the top of a hospital bed, just because you bend your knees isn't very good. It's quite difficult. So that's why we want to emphasize the importance of the reasons behind the biomechanical principles, not just the principles themselves. As a result, the presentations are very, very interactive. I tend to tell the clinical staff the worst part of any presentation is me having to stand here for an extended period of time talking to a quiet crowd. Yeah. And also the fact that these nurses, some of them, again, are quite, they've been nurses for a very long period of time. And they've done more lifts and more transfers than I have as an educator. So they can teach me a thing or two, right? And I want that interaction. I remember Dwight, who presented with respect to the Canada Post presentation, talked a lot about trust. And I think that's, again, I sort of just reiterate that it's very, very important to have that trust so that people will listen to what you have to say. Otherwise, it's going to be one in one ear and out the other. Okay, so the next part of the back care program at West Park includes a back care resource person. And obviously Shirley had said that in the past we had attempted to do this, but because of the changeover in staff, it wasn't quite kept up. So this time it's going to be a bit different, particularly because we add an annual education course to the chosen back care resource people. And they get not just a presentation regarding just general biomechanics and unit-specific education, they'll get the whole thing. The education, obviously, of the general mechanics, but also of all lift and transfer procedures and how they would pertain to each unit, so that if somebody were to move units, one, we keep track of that, and two, they'd be able to provide their expertise and their knowledge to whatever unit they go on. Because, between a unit that has predominantly cognitive impairments or behavioral issues versus a neurological population, the transfers and what nurses and clinicians need to know on a day-to-day basis, very, very different. Presentations are done by an occupational therapist, myself, and really it's trying to make sure we keep as comprehensive as possible while ensuring that there are the minimal number of hands in the pot to complicate things. Okay, and this is, I think, the part that I really like to emphasize, because I find that this is where I get the buy-in. This is where I get the trust in my patients. That's this. I'm not sitting behind the table. Each presentation is geared towards the specific challenges and the unique needs of each program population. So each unit gets a different presentation. Obviously, there are going to be some similarities. For example, general biomechanics isn't going to change from one unit to another. Lifting a patient handling is going to be similar from a biomechanical perspective, unless, of course, you have an amputee unit or somebody with altered anthropometrics. But other parts of it are different, and the focus of these presentations should be different. So, for example, on our chronic assisted ventilatory care unit, those patients are total care. They need assistance to turn in bed, they need to be repositioned, they need assistance to go shower, go to the bathroom, feed, all sorts of things. So it's quite labor intensive. So in discussion with that program's clinical staff as well as their manager, we decided to focus on energy conservation techniques because of the volume of work that these people have to do on a day-to-day basis. We have a small satellite facility called Gauge Transition to Independent Living, or GTIL, and there are very few clinical staff there, separated from the facility itself. And the focus for them was more on situational clinical reasoning. And the reason why is because the facility is a transition to independent living, which means the patients themselves are encouraged to lead their care. So asking the staff, lift me, help me do this, help me do that. Whereas I think a lot of the staff require just a little more emphasis on the importance of ensuring that what you're doing is safe, even if the patient is asking you to do it. My example is saying one of the patients would ask one of the support staff, can you help me transfer a certain way? Because a previous staff member helped me that way. And the support staff said, sure, what is it? Well, they asked me to do it, I asked them to do it blindfolded with one hand behind their back, hopping on one leg. And, well, that's where you use your clinical reasoning and say, no, let's do this a safe way that is both safe for you and safe for me. Finally, in ABIBS, which is the Acute Brain Injury Service, there's significant behavioral issues. And for those, there's not a lot of ceiling lifts and transfers and those types of issues involved. So what we decided to go with, again, in discussion with the manager and on the ground staff, was a focus on worker-safe handling techniques. How to disengage with a patient if they are becoming violent or if you feel unsafe. I don't know how many people here are healthcare providers by background. Raise your hand. Anybody who's ever had sort of a nursing or a transfers education back in the late 80s was taught the bear hug technique was the best way to lift a patient out of bed. Now, unfortunately, the bear hug technique is, while very good mechanically in some respects, very bad in that for this particular population, if they go down or even they decide they don't want to stand up and they go down on purpose, the only thing they have to hold on to stop their descent is a nurse standing like this directly in front of them, falling forward as the patient drags them down to the bed. So there has to be a different way. And those injuries are those acute injuries that happen that take quite a bit of time to recover from. So our focus really was on that worker-safe handling technique to make sure they were able to disengage and they felt safe doing what they do. So this is just a quick sample slide of the presentation that we are performing. And again, it's really, really interactive and it's discussion-based. These are issues like the height of the bed. If there are two caregivers working on a ceiling lift, what should the height of the bed be? We've seen a lot of examples, great examples in the industrial sector of variable height tables so that each worker can specify their own work table height. That gets complicated when there are two caregivers and it's actually mandated that two caregivers should be there. So what do you do? These are, again, the issues that we talk about because these are issues that the nursing staff have brought up during those meetings and are interested in them. Other ones, pushing away versus pulling towards, which one is more mechanically efficient, which one is safer, as well as what's supporting a patient during their transfer versus physically lifting a patient. These things are actually clarifications that nurses clinical staff really like to have so that they know exactly what they're doing and it gives them more evidence and more information to make their clinical decisions. So in terms of continuing our presentations, generally speaking, we'd like to have less than, 15 or less clinical staff per presentation. And in order to do that, we have multiple presentations. And at the end of each presentation, all the attendees fill out a feedback form and provide written comments regarding the presentation. The presentation is obviously modified as needed based on those comments, and so that we can do better next time. These are our scores, actually, for the feedback so far, and these are from about 120, I think, of our clinical staff. And even though, again, the variability goes all the way from a 5 out of 5 to a 2 out of 5 in some disgruntled, unhappy people.
Style and format.
Who obviously have, for the majority, it's quite high. We've had good success and we've had good buy-in. I know a lot of the comments are that the presentation was well written and very interactive so that the nurses felt like they were learning something. It wasn't just a presentation by somebody standing up and talking for minutes and minutes on end with no crowd interaction. Program results. So the program was initiated early this year. January was one of our first presentations. And we've seen a decrease in back injuries. We do have some stats in the next slides. And the important thing is actually, what was surprising is we found that there was no incidence of back injury on a unit that received the back care presentation since its initiation. That's really impressive. We're really happy to see that. In terms of the incidences of overall back injuries from 2010 to 2014, everybody can see that marked drop between 2013 and 2014. Obviously, the year's not done yet, but this data was actually collected less than a month ago. So hopefully, everybody fingers crossed, we don't have a huge rash of accidents. Overall repetitive strain or MSD injuries trending down, and especially again in 2014. where you see a huge decrease in those values. So in conclusion, really our keys to success and what we find was the most important pieces of our program was this comprehensive safety program. Again, not just by clinicians and not just by staff, but also across time to make sure that people that have been at West Park for 25 years still have the same refresher courses that somebody who's only been here for 2 years have. Management level commitment to ongoing training, obviously very important. Organizational support, making sure that we have those rooms available so that we can work in the environment that the clinical staff work in, as well as the customization of those programs customization of the presentations by program. Because again, it's very important. People on the neurological unit kind of don't have the same focus as somebody on an ABI floor. So it's important that we make sure that those presentations are done and geared towards the staff and what they do on a day-to-day basis. Otherwise, as Dwight said, there's no trust. Any questions?
I was wondering, lift teams and lift assist teams have been very successful in the U.S. Is that something that you examined implementing here?
So to be honest, we didn't go to literature to look at what other models are out there. We were struggling with previous models that we've tried and having external people come in to do the training. And when we did the pilot with the occupational therapists on the one particular unit, where it seemed to be very successful having that relationship and the buy-in from the team, because it was a staff member teaching the training who knew the patients and knew the model of care and the service delivery for the unit. We found that that was so powerful, we wanted to build on that. And we are a very small organization as well. And so trying to mobilize the resources in such a small organization can also be a challenge. So that's what led us to the direction that we took. But thank you for that. That's an interesting concept to look into. I hadn't heard of the teams.
Is the refresher training that you do mandatory?
Yes, it is. And what we do is up on the units, we enlist the unit secretaries or unit clerks, it depends, because again, being a small organization, every unit functions slightly differently. And we have them do the scheduling, and we just open up times to say, these are the different days we're available. We block in the times until we get about 75 to 80% of the staff covered on that unit, and then we move on to the next unit. Generally, when we hit 75 to 80%, the only people left are the nighttime people, and that's where we try to schedule. We have the unit clerks, again, then look at scheduling that person to work with their back care resource person on the unit for their refresher.
So would the same principle apply to someone who works part-time and doesn't work often?
Yes.
They're caught by the
Yes.
back care specialist?
Can we come back? There's the question at the back.
Your statistics, are they based on your WSIB, like grade injuries, or are they reported incidents, like not necessarily an injury, or are they actual, are they incidents or injuries?
They're reported incidents collected by Occupational Health and Safety. So, Suzanne, this is the data from Derek. Do you know if they would be the WSIB reported or just all incidences?
No, I think they only get reported if they have lost time or need modified work. So this would be based on the number of incidents that have actually been reported, not the number of incidents that become a WSIB claim.
Back to the front.
Sorry. In your presentation, you mentioned that your training is interactive. Is hands-on a general rule, or is this something that just happens randomly during your training sessions?
It is very hands-on, and while we try not to have a set schedule to the presentation itself, really whenever somebody asks a question or says, well, why don't you do it this way? That's when everybody in the presentation, which is why we try and keep it to a low number, gets up, comes over to the bed comes to the bedside and actually attempts to do the actual transfers or lifts that we're recommending, tries to implement those recommendations, and seeing how they do it not only educates themselves from more of partly from muscle memory, but also from experiential learning. it also helps inform me as to how that particular group likes to learn or how we can direct that particular presentation.
Could you give an example of what one energy conservation technique is?
A good energy conservation technique, specifically to, I guess, repositioning a patient up or down a bed, because if a patient sort of slides down to the bottom of the bed, then it's much more difficult to perform patient care with them, turning them, all sorts of things, or even lining them up with the ceiling lift tracks. So what traditionally nurses and care staff have done is grab the sheets that the patients are lying under and shift them up. One of the energy conservation techniques that I teach them is, because everybody in the hospital has access to a full hospital bed that has tilt and adjust, I recommend that they tilt the bed so that the patient is already a little bit angled down towards the head of the bed, thereby decreasing the amount of friction and using gravity as an assist. So that's one of the energy conservation techniques we recommend.
You guys can just pass it back to
Sorry. So the multi-component patient handling strategy that you talked about, you implemented that in January of this year? And you've already seen a reduction in injuries?
Program development for this actually started early in 2013. So we didn't actually roll out the presentations or roll out the system until we knew we were fully ready to implement it on a wide scale.
Mm-hmm.
So it wasn't sort of a soft rolling in, it was, we made sure that what was there was available to the staff.
And your sorry.
That covered half the hospital. So
Mhm.
we started because we have different patient populations as well. We started with one unit, the CVC unit, and then we moved on to other complex continuing care units that would have a similar population. And then our gauge, which, while a different environment, again, same population. And then the next step is moving on to the rehab side where the patients are more ambulatory. So things will be modified quite a bit as we move over there. So this covers about half the hospital from January till now.
So your policy would be a no lift or minimal lift?
No manual lift.
No manual lift. Okay. And I'm sorry, but your aids, what sort of aids are you using for, let's say, repositioning? Because for us, we're still getting responses like, oh, we don't use the lifts, we just use the soaker pads,
Yeah.
which was fine 20-something years ago, but
Yeah. On the complex continuing care units, all patients, well, for any actual patient, it just happens more often on complex continuing care. If the patient's not able to participate in shifting their weight, all patients will have a repositioning sling under them unless medically contraindicated. So we do have one or two situations where, because of the patient's contractures, the ventilator, and all of the other things with that patient, it would just be too difficult and unsafe for the staff and the patient to use that repositioning sling. That's when we resort to either a soaker pad and/or we have transfer gloves. They're sliding gloves that help as well, and we've used those on some of the units.
How do you find, or what kind of reaction have you had from the employees that I referenced earlier? 25 years in the job, I know my business. Who are you coming on the floor telling me what to do?
Can I just, before you answer that? I used to work on the units. I'm an occupational therapist by background, and I was actually looking really forward to Matt going up, and I didn't warn him, and I thought, I can't wait till I hear from my friends, the nurses I worked with for 20 years, to be like, who's this young guy coming up? And I actually really had to eat crow getting all this feedback back from the nursing staff, and I'll let him answer a little bit, but the two of us have been invited to the Respiratory and Vent Services Christmas party, big dance thing, and we got personal invitations brought down to us from the unit. I don't know how we did it, but so I'll let you answer that.
Thanks for fielding that question, Shirley. Any other question? Well, basically, part of what I do is, again, talk to the staff. The very first thing, right around the second or third thing that I say in my presentation is, even though I'm here making this presentation, regarding back care, and I know the mechanics behind lifting and the technical aspects of it. You guys as nurses and clinical staff are the ones that do it on a day-to-day basis. I'm not here to teach you how to do what you know how to do day in, day out, and that you do day in, day out. The main purpose of what I'm here to do is make sure that if you have any questions or you have any concerns, we can discuss them, and we can make sure that we address them so that you feel safer doing what you do. So it's, again, like I said, a horrible presentation would be me standing up and receiving absolutely no feedback from the clinical staff, because at that point I'm lost with my presentation. Where do I go? How do I teach whoever's in front of me what they want to know, not what I want to tell them? You two done?
Something else from you.
Okay, well, let's round of applause for these folks, and we'll continue later.